Hello everyone, I am Dr. Mahalakshmi, educator, forensic medicine and toxicology. In this, we are going to see about general introduction of toxicology, the general aspects of toxicology, what is toxicology and what we are going to see in forensic toxicology. All these things we will be seeing in this introductory chapter. So first, what is a poison? What is the definition of poison? According to the textbook, the definition is that poison is a substance which when introduced in small quantity produces ill health in very short interval. Like even if it is introduced in a very small quantity, it will cause ill health in a very short interval. This is a or somewhat definition of this poison. And this poison, when you study about the ill effect of this poison, effects of poison in body and its treatment is clinical toxicology. Clinical toxicology is when you read about what are the changes it creates in the body and how you will treat them. This is clinical toxicology. And if you apply this toxicological knowledge, like your knowledge about the poison in administration of law and justice, it is forensic toxicology. Like every forensic definition is the same. You will use the knowledge for administration of law and justice. For law and justice administration, you will use the knowledge of toxicology. You will use toxicological knowledge. This is what forensic toxicology is all about. So, here what you will be seeing is, we will be seeing what are the poisons, homicide poison, suicidal poisons, what are the symptoms that you will be presenting with when you consume those poison, and what are the possible diagnostic method that you can use to understand the type of poisoning, and how will you treat it, and what are the post-mortem changes it can cause. This is our main motive in studying this forensic toxicology. And few introduction terms that we have to know in this toxicology. First is LD50, otherwise known as lethal dose 50. Like this is the concentration of drug. Like this LD50 is the concentration of drug that is lethal to 50% of population. Clear? If you use this concentration, then if you have 100 people and use this much concentration of the drug, at least 50 people will die. That is your LD50, your lethal dose 50. Clear? Next is therapeutic ratio or index. This therapeutic ratio, it is achieved by dividing this toxic dose by effective dose. So, T is toxic dose, E is effective dose. So, you get the toxic dose. So, that's something that is very toxic to people. Effective dose, like if you take a medicine, some pharmacological medicine, if you take, there has to be a dosage, right? Only if you give that in that dosage, it will be able to do its work inside your body. So, that is the effective dosage. But if you give it too much, it will become lethal. And what is that dosage? That is toxic dosage. If you divide these two, you will get something known as therapeutic ratio or therapeutic index. This therapeutic index, if it is higher, that is the difference between this effective dose and toxic dose, if the interval is longer, then it is a better drug. Like we have one drug with 50 milligram as effective dose, and we have another drug and the same drug with 60 milligram as toxic dose. Then you will have a reduced therapeutic index. Then there is more chance that patient may die because of overdosage. So, this more the gap, it is always better. So, therapeutic index, if it is higher, it is better drug. This is therapeutic index. Next, what we have is toxin and venom. So, we already saw what is a poison. There is something known as toxin. There is something known as venom. There is one more thing known as toxicant. So, what is the difference between these is that toxin is a poison produced by living organism. Like bacteria will produce botulinum toxin. You have Shiga toxin, E. coli. Like all the toxin byproducts produced by the living organism is known as toxin. And venom is something which is poisonous when injected. Like if you take a snake venom, if you digest it, if you ingest it, you will not have any symptoms. But if you inject it into your body, there will be death. So this kind of poison, only when injected, they will show its action. Those poison are called as venom. Toxins produced by living organism, and this venom, it will act only if it is injected. Next is toxicant. Toxicant is something produced by non-living substances. So it is produced by non-living substances. This is toxicant. And who is the father of modern toxicology is Urfila. He is the guy who deals with all the toxicology, modern ideologies regarding toxicology. He is the one who pioneered everything. So he is known as the father of modern toxicology. So this is the basic thing that we have to deal in general toxicology. Now we will be seeing what is the classification of poison. We have homicidal poison, suicidal poison, and accidental poison. So to call something as an ideal homicide poison and ideal suicidal poison, there has to be certain features. What are the features? We will see. This is usually asked in the exam. So what are those features? First, it should be colorless. So whenever you want to say something as an ideal homicidal poisoning, how will you do homicide? Without knowing, you have to add it to the food. You have to make them take that poison. So it has to be very, very conspicuous, right? So colorless, odorless, tasteless. It should not have any color, should not have any odor or any taste, and it should be easily soluble in food and drink without causing any change. That is the main motive. They should not be able to notice the change, right? So it should not cause any change to the food. And the effect of the poison, like how it causes the symptoms and all, it should resemble a natural disease, and a clinical diagnosis should be difficult. That's how you can escape, right? If it resembles a natural disease, then you can easily escape without doing anything. So it should be like that. And onset of sign and symptom should be very slow. So slower the drug action, it will be much better. No one will have any suspicion over you. And it should be difficult to associate any sign and symptom to the poison. Like the poison and the symptom, it should not match at all. It should be like that. And it should be very low toxicity. Like the fatal dose should be very low and the toxicity should be very high. Meaning you don't have to add some 100 mg or 100 gram of poison. Like even 1 mg should be enough to kill that person. So that fatal dose must be very, very small, but the toxicity, it should be very, very high. Even 1 mg should cause death. That kind of item is preferred as the ideal homicidal poisoning. And everything opposite to that would be a suicidal poison. So it can be any color or odor or any taste, preferably sweet. But like if you are going to kill yourself, you won't mind the color, taste or the smell, right? So anything you will consume. And solubility, anyway you are going to eat it, so there is no issue. You don't have to hide it and drink it. So there is no such requirement. And signs and symptoms, the main criteria would be you should cause a painless death. That would be the main criteria. And onset of sign and symptom, it should be quick. You don't want to suffer along. So this should be the criteria for suicidal poisoning. And fatal dose and toxicity, there is no such requirement. Even if you have to take some 5 mg, 10 mg, you will be able to take. So this is the ideal suicide poisoning and ideal homicide poisoning. This ideal suicide poisoning, it is very important. They will ask you what should be the feature of ideal homicidal poison. Now you have another classification of poison, that is system wise, how it acts. So you have first corrosives, which will cause erosion. Then you have irritants, So, in irritant you have metal, non-metal like phosphorus, you have plant irritant like resinous, croton, all those. Then you have animal irritants like snake bite, scorpion, all those animal irritants, it is there. Apart from that, you have system wise CNS stimulant or deliriant and depressant. You have serious cardiac poison. Then you have asphyxiant, respiratory system poison, you have asphyxiants. So, these are the general classification, like which system it is acting, how it is causing the toxicity. So, all these are the classification of poison, and each and every poison you should be able to number one thing. So, metal, you have all the heavy metals, right? You have mercury, lead, all those things. Non-metal, you have phosphorus. Plant, you have resinous. Animal, you have snake. For CNS stimulant, you have datura, which will lead to delirium. Then depressant, you have all the alcohol, ethanol, methylol, barbiturates, everything. Cardiac poison, you have digitalis and aconite. Asphyxiant, you get all the irrespirable gases, carbon monoxide, then hydrogen cyanide also. So, all these gases, it causes asphyxia. So, this is general classification of poisoning. It can be either classified into homicidal, suicidal or accidental, or it can be caused by like what is the system it is affecting, according to that also it can be classified. So, this is the classification of poisoning, and this may also be asked in the exam. Now, we will look into the management part. So, this is where we usually come. So, doctor, we should know how to manage a case of poisoning. So, whenever the patient comes, your first priority would be this FABCDE, airway, breathing, circulation, decontamination, elimination, and brain activity. So, this like you have to secure airway, you have to secure the circulation, you have to secure the brain activity. Then you have to do decontamination, like whatever that is already present, you have to prevent them from getting absorbed, and whatever already absorbed, you have to eliminate them from the body. This should be your ideology while treating a toxicology case. So, first airway, then you have the brain activity, then you have the circulation, then you have the decontamination and elimination. So, this is the thing we have to know. So, first we have the removal of unabsorbed poison. How you will do? If it is an inhaled poison, you have to give oxygen, or you have to give fresh air, like just by taking them away from that area and by putting them in a fresh air region, you will be able to prevent the absorption. And if it is something like carbon monoxide or irrespirable gases, if you give oxygen in enough concentration and pressure, it will prevent them from inhaling further poison. So, this is for inhaled poison. If it is an ingested poison, there are certain things that was done in the previous time. One is emesis, another is whole bowel irrigation. Now, both are not done. Like this whole bowel irrigation, it is rarely done. Emesis is completely avoided. This whole bowel irrigation, like very rarely it is being done. And in this ingested poison, the most important thing we have to know is gastric lavage. So, gastric lavage is also known as stomach wash, and this is done when there is a high quantity ingestion, and if it is a toxic substance, it has to be a toxic substance, it should be ingested in a high quantity, and it should have been a recent ingestion. Under these criteria, we will be doing stomach wash or gastric lavage. And what is the contraindication for this is that absolute contraindication is when there is more chance for perforation of the stomach. like your corrosives, or ingestion of sharp object. These two can lead to perforation of the stomach. So, because of that you have to avoid stomach wash. There are certain relative contraindications. So, your relative contraindication would be like coma, advanced pregnancy, esophageal varices, convulsant drug. Under these conditions, if they are not conscious, like unconscious, there is more chance for aspiration and also more chance for perforating the stomach. So, these are relative contraindication, and in kerosene there is more possibility for chemical pneumonitis. So, in kerosene also it is relatively contraindicated. So, these are the conditions where you will not do gastric lavage, and if you do gastric lavage you will use this tube known as Ewald's tube, and the position would be leg high and head low. This is the position that you will use for doing this gastric lavage. And this gastric lavage, all the fluid that you collect. So, the first wash should be preserved, and it should be continued till you get clear fluid from the stomach. So, this is how it is done. So, you will insert this tube, you will put saline inside. Sometimes depending upon the poison we will use other solution like potassium permanganate and all. So, depending upon the poison you will instill saline or other substance inside this tube, and you will wash the stomach and you will take away the refluent. So, this first wash it should be preserved and sent for toxicological analysis. Any vomiters should also be preserved for toxicological analysis. So, this is about like prevention of further absorption of poison. Now, there must have been some poison which would have been already absorbed. So, we have to do measures to remove that poison. So, for removal of absorbed poison from body, what you can do is you can do forced diuresis. You can increase the urination, or you can do urine acidification and alkalization. So, what will happen is that when you ionize the poison, it will not be able to escape from excretion. So, you will basically, if it is an alkali, you will acidify the urine. If it is an alkaline poison, you will acidify the urine. If it is an acidic poison, you will do the opposite. Like if it is acid, like you just do the opposite, so that the charge will be not there and it will easily go through the membrane and it will be easily excreted. So, this is what you basically do in the acidification and alkalization. And in alkalization, what are the drugs that can be done? Phenobarbital, salicylate, all the acidic poisons you can do this alkalization. Methotrexate, and it is contraindicated in congestive cardiac failure, renal failure and cerebral edema. Any volume overload condition you should avoid this alkalization. Acidification you can do in phencyclidine, amphetamine, cocaine and quinine. So, all these you can do this acidification. Clear? Next, what can do is hemodialysis. Hemodialysis is done for this blast poison. Barbiturate, bromate, lithium, alcohol, salicylate, strychnine, theophylline, thiocyanates. So, this is where you will be doing blast. And peritoneal dialysis, hemoperfusion, hemofiltration, all where you will be just getting the solvent away from the blood. All the poisonous solvent you will be taking them away from the blood. So, this is how you remove the poison that has already been absorbed in the system. To prevent absorption, you will do gastric lavage. To remove the poison that is already in the system, you will do all these. Like dialysis you will do this acidification and alkalization, then hemoperfusion and hemofiltration. All these are methods to eliminate them. Now, there are another methods which will help us to deactivate those toxins. That is, we will physiologically, we will try to take the poison away. So, these are antidotes. and based upon their mechanism of action, based upon the mechanism of action of antidotes, you have these types. So, it will do toxic effect bypass, like the toxic effect of the carbon monoxide. Even if the poison is present in the body, if you give this hyperbaric oxygen, the toxicity will go away, right? So, it will not go directly deal with the carbon monoxide. It will go do its duty. The hyperbaric oxygen or normal oxygen, it will go do its duty, and once it keeps on doing its duty, the carbon monoxide will get eliminated. So, this will completely bypass the toxic effect on its own. So, this is first step, toxic effect bypass, and it is seen in oxygen in carbon monoxide poisoning. Next, you have inert complex formation. This is very, very important, that is chelating agent. So, here what will happen is that this chelating agents, they will go attach to the poison and they will form a complex which is excreted. So, previously poisonous substance, when it is attached to this chelating agent, will become non-poisonous and it will be eliminated from the body. So, this is inert complex formation. Next is accelerated detoxification. For paracetamol, you have the accelerated detoxification like N-acetylcysteine. This is the antidote for paracetamol. This will help in accelerating the detoxification. So, here N-acetylcysteine will detoxify the excess amount of paracetamol. So, this is how you will eliminate the poison from the body. Next, what you have is reduced toxic conversion. This is what happens with alcohol, methanol, like ethanol to methanol. So, all the drugs, all the methanol, it will go utilize the enzyme so that methanol will not be converted into formic acid. So, this reduced toxic conversion will happen because of your antidote. So, this is another mechanism. Then you have receptor site blockade. When you have all the OP components doing all the acetylcholine receptors activation, you can give atropine, which is an antagonist, right? So, this receptor site will be blocked by this atropine, which will give you improvement in the toxicity. So, this atropine for OP components, this is a receptor site blockade. And you have a receptor site competition, like this, it will go compete with the poison in the same receptor. So, naloxone for opioids. So, opioid and naloxone, they will compete each other to act in the receptor. So, this naloxone will throw away the opioid and it will sit in the receptor. Because of that, the toxic effect of the opioid will be forgotten. So, this is how the mechanism of action divides the antidotes into 6 classes. You have toxic effect bypass seen in oxygen and carbon monoxide, inert complex formation, chelating agent, accelerated detoxification, N-acetylcysteine for paracetamol, reduced toxic conversion by ethanol and methanol, receptor site blockade in atropine and organophosphorus compound, receptor site competition in naloxone for opioids. So, this mechanism of action, classification of antidotes, this is also important question. They will ask you what are the mechanisms and what are the examples for that and how it affects the toxicity. Like that they will ask you. Next, you have mechanical antidote. So, mechanical antidote, right, by physical means it will prevent the poisonous activity. So, you have this first important thing is activated charcoal. This is the important mechanical antidote. Like it acts by the principle of adsorption. So, it will adsorb poison onto its surface. So, what happens is that there is something known as destructive distillation which will create this activated charcoal. So, this is very, very porous with large surface area. It will have large surface area which will absorb all the poison onto its surface. So, because of that it will be easily eliminated. You will not get any toxicity. So, this is the mechanical antidote, and this mechanical antidote, there are certain contraindication. It is contraindicated in pesticide, hydrocarbon, heavy metal, intestinal obstruction, acid, alkali, alcohol, lithium and seizure disorders. So, you can remember by high slap. So, these are the conditions where you are not supposed to use activated charcoal. Sometimes you will do something known as multi-dose activated charcoal. Multi-dose activated charcoal. Here you will give this 50 gram of activated charcoal every 6th hour for 3 days. By that you will be able to completely take away all the poison in the body. So, this is multi-dose activated charcoal and it is contraindicated in few conditions, which is this. You can remember by this high slap mnemonic. Next you have demulcents. So, it will form a coating. It will form a coating over the stomach, thereby preventing the absorption. Diluents, it will dilute the poisoning. It will dilute the poison concentration in the body, thereby preventing the toxicity. So, by physical means they prevent. First is activated charcoal, then you have the demulcents and you have the diluents. Finally, you have the chemical antidotes. So, chemical antidotes, they will be chemically opposite to each other, like acid to alkaline. Like they will be, by the chemical activity, they will overcome their action. Example is copper sulfate for phosphorus, dicobal irritate for cyanide. So, these are chemical antidotes. Then you have chelating agents. So, chelating agents, it is also an important question. They will ask you what is the chelating agent and they will ask you to explain in detail about one of the chelating agent also. So, what is the mechanism of action of this chelating agents? They have this extra sulfhydryl groups in their body. So, these agents, they have this sulfhydryl bond and to this sulfhydryl bond all the heavy metals will come and attach. So, heavy metals will attach to this sulfhydryl group. Clear? So, this is how, like normally the sulfhydryl group is present in many important enzymes in your body. To that enzyme only the heavy metals go and attach, cause toxicity. But when you introduce this chelating agent into your body, this sulfhydryl group present in this chelating agent will attract all the heavy metals. So, heavy metals will come and attach to these and it will form an inert complex which will be easily excreted by your body. So, this is the mechanism of action behind chelating agents, that is inert complex formation, and we will see each and every chelating agent. So, first is your penicillamine D. It is given mainly for copper toxicity. It is mainly used for copper toxicity. Apart from that, it is also given for mercury and lead. You can remember CML, copper, mercury, lead. This is penicillamine D. Next you have EDTA. You have calcium and disodium EDTA. This is specifically given for lead, exclusivity for lead. This is given only for lead toxicity and it can be given IM and IV, but IV is preferred. And the dosage should be maintained properly in case of CNS toxicity. So, TNS toxicity, it should careful administration should be there. And it is highly contraindicated in case of hepatic failure, renal failure and anuria. Under these conditions, you should not give this, and there is possibility, like if you give without this calcium disodium EDTA, without that if you give a simple EDTA, there is chance for hypercalcemia also. So, these are the contraindication for EDTA which is given exclusively for lead toxicity. Next you have desferoxamine given exclusively for iron. For iron toxicity, you will give this desferoxamine. Next what you have is dimercaprol. This dimercaprol is very important. It is also known as BAL. So, BAL, it is a British anti-leukicide agent. This BAL is indicated in MAL. You have mercury, arsenic and lead. This is where you will be giving this, and it is contraindicated in iron, organic mercury and copper. So, these you should not use dimercaprol. And mode of administration, it is given only IM. IV is contraindicated because of chance for fat embolism. And to counteract this, they came up with DMSA. So, this DMSA, it is mainly for giving IV administration. IV administration. This is an analog. It is an analog of BAL used mainly for IV administration, and organic mercury also it is given. So, contraindicated in iron, organic mercury, copper, cadmium also it is contraindicated. But DMSA, it is an analog of BAL. It is used in organic mercury, and IV administration is also done with this BAL. So, BAL given for mercury, that is inorganic mercury, then arsenic and lead. Mainly arsenic, this is the first line of management. So, these are the important chelating agent we have to know. Penicillamine for copper, desferoxamine for iron, you have EDTA for lead, then this BAL or dimercaprol for this mercury, arsenic and lead. Next, you have few other, like for nickel you can use DDTC, and for thallium you use Prussian blue. So, these can be asked in MCQs. So, this is also important. So, finally, you have the serological antidote, which is your venom, like anti-snake venom. All these comes under serological antidote. Then physiological antidote, you have the physiologically opposite things like your atropine, physostigmine. Things that are physiologically opposite to each other, they have opposite action, will come under this physiological antidotes. Now, these are the things. First, you will prevent the absorption. Next, you will eliminate that has been already absorbed. Then finally, you will give antidotes. Antidotes, we saw the mechanism classification. Then we saw how it is doing, like chemically it is doing, physically it is doing, then physiologically it is doing, and chelating agent, how it is acting, that also we saw. So, this antidote, it is very, very important. Now, finally, what are the duties of a doctor? If you come across a case of poisoning, what you have to do is, medically you have to treat. That is very important, and this is the first line. This is your priority. And legally, you have to intimate the police. All the poisoning, you have to give information to the police. And you have to preserve evidences. Your stomach wash and all, you have to preserve it. And you have to send sample for analysis. Sample for analysis you have to do. So, all these comes under responsibility of a doctor whenever they come across a poisoning case. Medical duty is the first and priority, and legal duty, intimation of police, preservation of sample and evidences is very important. So, this is all about general toxicology. Thank you for watching.